Hello, everyone. My name is Ivan Wong. I'm from Dalhousie University in Halifax, Nova Scotia, Canada. So we'll talk about what happens when everything's failed with management of cuff tears. Now what? These are my disclosures. So by the end of the session, you'll be more familiar with treatment options for large and massive rotator cuff tears, the technique of maximal or partial repair, techniques of superior capsular reconstruction, techniques of interpositional bridging allograft reconstruction, and the outcomes of these. So rotator cuff tears, as you know, are very common. About 6 million cuff tear patients in the US greater than 65 years of age. Non-operative treatment really doesn't seem to result in optimal outcomes. Over 300,000 repairs are done annually, and patient expectations are rising, which makes it even more difficult to treat these patients. Unfortunately, about 20% of the rotator cuff tears are large and massive, and these usually start with tendinopathies or non-traumatic tears and then progress and get larger. It's getting more common now with failed cuff surgery like we're talking about here. So how do we repair these massive rotator cuff tears and if they have failed? Well, debridement really has been done in the past. It can result in good outcomes for low demand or elderly patients. And you can result in an increased progression of osteoarthritis, as well as a higher reoperation rate if you just do a debridement. Older patients are really best treated when they have an irreparable cuff tear with a reverse total shoulder. However, the problem is with younger patients without significant arthritis, you would actually lose out on lots of different options. So different options right now are partial repair, superior capsular reconstruction, tendon transfers, subacromial spacers, and bridging interpositional grafts. The repair really has been the gold standard treatment for massive cuff tears. Large and massive re-tear rates, though, are somewhere between 50 and 90% as they get larger because there's so much pressure on tension on these repairs. And the weak link is thought to be the suture tendon interface. Burkhart's really made the description of the suspension bridge type of a repair in which the concept is to recreate that rotator cable to allow for functioning of the cuff, even though we don't have fully repaired back onto the greater tuberosity, similar to a suspension bridge. This is a study in 2010 looking at the revision rate of arthroscopic rotator cuff repairs. That's a level 4 study following up for almost 3 years. They did find that there was improved ASES, simple shoulder test, range of motion postoperatively. However, half of the revision repairs were not intact, and patient age and number of torn tendons led to or predicted tendon integrity. So successful revision repairs were 70% if it was only single tendon, but only 25% if 2 tendons. So the larger the tear, the worse the chance for it to heal. So they've actually suggested other things. So if with partial repair, we can consider something with an augment. So what we call is a maximal repair with augmentation. And the goals of a rotator cuff repair is to eliminate pain and restore shoulder function by repairing the cuff tissue. Obviously, the problem here is the tendon quality and tissue vascularity, because if it's failed before, it's going to be even harder to heal afterwards. So healing is the most important predictor for success of surgical management. And recent studies are finding that bioinductive scaffolds are helping with this healing. This is probably one of the best randomized controlled trials out there. This is in 2012, level 2 multi-center randomized controlled trial looking at large tears that were almost repairable and then augmenting with the dermal allograft, of which they found 100% improvement in healing compared with those without augments. So this is a significant improvement when you're using an augment for maximal repair. We've actually done a systematic review in 2016, which supports this. So there is evidence in the literature to support use of acellular dermal matrix for primary augmentation of cuff repairs to improve outcomes. Other options that are more common right now are superior capsular reconstruction. And superior reconstruction is really popularized by Mihara. This is his initial study in 2013, looking at 24 shoulders with a fascia lata autograft. He followed them for almost 3 years. Again, got significant improvement in the patient-reported outcomes. MRI showed 83% intact repairs, which is fantastic, and preservation or improvement of the acromiohumeral index. Of course, he's using fascia lata. Other studies out there don't seem to get the same type of MRI healing. In this one with Burkhart, Tokish in 2018, find MRI healing of under 45%, of which they described a clinical successful outcome in just under 3/4 of the patient, only following for a year. This has led to increased popularity of SCRs. Everyone hears about it. We're apparently worldwide, they're doing more than 10,000 of these. There's more than 500 grafts a month being used, but still there's limited outcomes for this and question about the complications with the cost of these. These studies right now are still poor quality evidence. The re-tear rate is somewhere between 3 to 36%. So we definitely need more outcomes to be able to decide how well this type of a procedure will do long-term. But this systematic review summary does show the rate of re-tears higher than what we were predicting and what Mahada has shown. Again, this increasing incidence of doing SCRs, this study here in 2020, systematic review shows good short-term outcomes. But again, we definitely need longer-term, better quality studies to describe what to do for these. The lack of outcomes with this is worrisome because we do not fully understand the mechanism of action and therefore the ideal indications for treating patients with SCR. In this study in 2021, most recently now is a retrospective review of 2015 to 2017 patients without glenoid cartilage loss, and 14 patients here followed for 2 years. And again, most people are meeting MCID for the patient-reported outcomes. There is some vascularity in that dermal graft, but they're still getting about 15% graft complications from this. They described failure as one or more of a conversion to reverse total shoulder or decrease in outcome scores compared to the preoperative scores. And in these patients, they found that it was successful in 80% or 20% of clinical failures when you consider either reverse total shoulder failure or decrease in patient-reported outcomes. The risks for these are female sex, presence of a subscap tear, and questionable whether BMI for reflection or lower preoperative acromial distance height for this. I've had my own experience with this, so I use it technically when there's no cuff available to do a rotator cuff reconstruction, which is my preferred technique. And my outcomes, I do have some failure. So again, kind of meaning in the literature about 15% of MRI failure, but we are getting improvement in work scores. So what about bridging reconstruction? Well, we've looked at our systematic review in 2017 showing that there's no level 1 studies, but the best comparative level 2 studies show that bridging is still better than repair. And how does bridging work? Well, it allows for connection of the remnant cuff back to the tuberosity to hopefully allow it to heal. It's different from the SCR graft, like you can see here, that we don't attach it to the glenoid, but attach it to the remnant cuff. And the ideal of doing something like this is somebody without glenohumeral arthritis, with or without proximal humeral migration, to be able to rebalance that cuff. So you finish what you do for a maximal repair, which means repairing the cuff maximally to the tuberosity, and then adding this graft with multiple sutures on it to distribute the forces and cover up that defect. So all the remnant cuff, instead of a suspension bridge, is fully connected to the greater tuberosity. And this allows us to have better connections. So we've done our initial follow-up after my fellowship in 2010, looking at this for follow-up for 2 years, showing that we got improvement in WARC, ASES, and UCLA scores. Very happy patients going through this. Preparing this graft is actually quite simple, of which they're able to look at and be able to tie these stick knots to be able to pass into the graft in sequential fashion. We're actually able to see an example of this type of a patient, which is a 45-year-old firefighter with a massive tear. This is what we would be doing for this type of a patient. We do it in a lateral decubitus position. And once we're able to do that, we can actually first measure the amount of defect, both medial to lateral, as well as anterior to posterior. So we can change the portal view looking from anterior to posterior to determine the amount. We then see how much reduction of this. And usually with these large tears, it's very difficult to get all the way back out the footprint, but we can actually retension this. And this whole process allows us to do that. And we retension it by repairing as much of it as possible back to the tuberosity. And by doing that, we can actually be sure that it's holding in the right spot. We get past the sutures through the edge of the cuff, each in sequential order so that we don't tangle it. And once we get them all sequentially in there, we can be able to pass the graft in through that cannula. When we get the graft in through the cannula, we can then sequentially pull on the sutures, get the graft tensioned appropriately, and get the lateral compression, just like a regular cuff repair would do. You can see here for healing, we get excellent healing for these. Most of the time, we're getting good outcomes and decreased pain when they do succeed. We've actually just submitted and got accepted our midterm 5-year follow-up of our 49 patients between 2010 and 2018. They have significant improvement in the work scores, lower score meaning better. We've actually compared our primary versus revision. So when we had to do a revision surgery, of which essentially what we found was revision surgery do improve just like the primary, but they're not quite as good as the primary repair. So if you're going to repair this initially, it's always going to be better for that. In fact, the quality of tendon is actually improved just the same, meaning that we can actually get healing of that tendon and functioning of those muscles. We've actually just completed our randomized control trial study here as well. This is published in AJSM, comparing maximal repair to bridging reconstruction. And we did find that work has significantly improved and significant decreased re-tear rates as governed by MRI, as you can see here. And these improvements has been sustained for 2 years. The biggest difference, though, is the partial repair. 20% of them did progress to end-stage glenohumeral arthritis, which there's no salvage for, and that becomes a problem. Why does this work? Well, we do think that the suspension bridge technique does increase the amount of forces at the level of the anchors, and by adding that bridging reconstruction, just like you see here, we distribute the forces and result in a lower re-tear rate. So my tendency, my algorithm is older patients get a reverse total shoulder, especially if they have arthritis. Younger patients without arthritis get a repair as much as possible. So if it's a small hole, we'll do a graft augmentation. If it's a big hole, we do a bridging reconstruction. If there's not enough muscle to reconstruct, I'd consider a superior capsular reconstruction. Thank you.